RN Link presents Recovery Audit Contractor by Marie Gould and Christy Zielinski. The presentation offers one continuing education unit approved by Board of Registered Nursing and accepted by Association of Clinical Documentation Improvement Specialists and American Health Information Management Association. Learning Objectives. Describe the background and purpose of the RAC program. Explain the RAC structure and audit process. Recognize high-risk audit target areas. Summarize the appeals process and financial impact. Apply CDI and coding strategies for denial prevention. Evaluate case study lessons to strengthen documentation practices. Disclaimer. The presentation is designed to provide tools to communicate information about clinical documentation, coding, and compliance in an educational structure. The presenter is not providing or giving legal assistance or advice but offer sensible and useful information and tools to obtain compliant results in the area of clinical documentation and coding. The educational materials provided in this presentation are carefully explored for its accuracy and usefulness. Best practice results and achieving outcome will differ in each hospital/facility and clinical situation. Origin. CMS pilot became permanent program in 2010. The Recovery Audit Contractor program began as a pilot in several states in the early 2000s. The goal was to see if hiring outside contractors could help Medicare identify and recover improper payments. The pilot was very successful, recovering hundreds of millions of dollars in overpayments. Based on this success, the program was made permanent nationwide in 2010 under the Affordable Care Act. A history of recovery audit contractors. In 2006, Congress authorizes CMS to launch the RAC program in New York, Florida, and California. In 2007, RAC program expands to Arizona, Massachusetts, and South Carolina. In 2010, RAC program rolls out nationwide. And in 2018, CMS reforms RAC program. Purpose of RAC is to identify improper payments. The RAC program's central purpose is to protect the Medicare Trust Fund. Improper payments include both 1. Overpayments, when a provider receives more money than they should, example is coding an inpatient admission when outpatient was appropriate. 2. Underpayments, when a provider is paid less than they should have been, less common, but RAC also identify these. This ensures Medicare dollars are spent appropriately and reduces waste, fraud, and abuse. Key functions and responsibilities. 1. Post-payment reviews. RAC primarily review claims after payments have been made to providers. They can look back up to 3 years from the date the claim was paid. 2. Identification of errors. RAC uses proprietary software for automated reviews to spot simple billing errors, example is duplicate payments, incorrect coding, and conduct complex medical record reviews, involving a team of medical professionals, for more nuanced issues like medical necessity documentation. 3. Recoupment and payment. For identified overpayments, RAC pursues the return of funds from the provider. For underpayments, they work with the appropriate carrier to ensure the provider receives the correct payment. 4. Contingency fees. RACs are paid on a contingent basis, receiving a percentage of the overpayments or underpayments they identify and recover, which has drawn some criticism from provider groups concerned about overzealous audit behavior. 5. Prevention of future errors. By identifying systemic errors, the program helps CMS identify opportunities for system improvement and helps providers avoid submitting non-compliant claims in the future. Focus on Medicare FFS claims. RAC reviews fee-for-service claims under Medicare Parts A and B. They do not focus on Medicare Advantage plans, Part C or Part D prescription drugs. Those are overseen by different programs. Since Medicare FFS covers millions of hospitalizations and procedures, it represents a huge financial risk area for improper billing. Key roles: detect, correct, prevent. Detect, find improper payments through data analysis and medical record review. Correct, work with providers to recover overpayments or repay underpayments. Prevent, share findings and trends to help providers avoid repeating errors. Think of RAC not just as auditors but also as a feedback loop for CMS and hospitals. Regional structure. The U.S. is divided into 4 RAC regions, each managed by a contracted company. The current RAC regions and their contractors are: Region 1, Performance Recovery, Incorporation. Coverage: Connecticut, Indiana, Kentucky, Maine, Vermont, Massachusetts, Michigan, New Hampshire, New York, Ohio, and Rhode Island. Region 2, Performance Recovery, Incorporation. Coverage: Arkansas, Colorado, Iowa, Illinois, Kansas, Louisiana, Minnesota, Missouri, Mississippi, Nebraska, New Mexico, Oklahoma, Texas, and Wisconsin. Region 3, Codevitae Gov Services LLC. Coverage: Alabama, Florida, Georgia, North Carolina, South Carolina, Tennessee, Virginia, West Virginia, Puerto Rico, and the U.S. Virgin Islands. Region 4, Codevitae Gov Services LLC. Coverage: Alaska, Arizona, California, Delaware, Hawaii, Idaho, Maryland, Montana, North Dakota, New Jersey, Nevada, Oregon, Pennsylvania, South Dakota, Utah, Washington, Wyoming, Guam, American Samoa, and the Northern Marianas. A national region, Region 5, is also managed by Codevitae Gov Services LLC and reviews specific claims across the country. Types of reviews: automated reviews. No medical record needed. Based on data only, example, duplicate billing, billing for services not covered. Semi-automated reviews. Start as automated, but the RAC may request limited documentation for clarification. Complex reviews. Require full medical record submission. Look for coding errors, insufficient documentation, and medical necessity. Most common area where CDI and coders are directly impacted. RAC process flow. RAC identifies a claim with potential error. Sends additional documentation request, ADR, to the provider. Provider has 45 days to submit records. RAC reviews the claim plus documentation. RAC issues a determination letter. Correct as billed. Overpayment, repayment required. Underpayment, provider due money. Provider has right to appeal if they disagree. Common coding guidelines and billing practices that trigger these automated reviews. Coding errors based on status. Services billed during none-covered periods. Exceeded frequency limitations. Medical necessity for specific demographics. Coding incompatible services. Incorrect edits National Correct Coding Initiative. Duplicate claims and/or services. Common coding guideline violations and billing issues that can trigger an automated RAC audit. Billing for non-covered services. Billing during inappropriate stays. Procedure to diagnosis mismatches. Incorrect coding edits. Unbundling. Inappropriate modifier use. Exceeding coverage limits. Gender-specific errors. Beneficiary eligibility errors. Duplicate claims and/or services. Medical records request for ADR RAC audit. Physician orders and certifications. Progress notes. Diagnostic reports, operative reports, treatment plans, discharge summaries, evidence of medical necessity, billing and financial records, valid signatures and credentials. Medical records request for complex RAC audit. Nurse's notes, informed consent forms, discharge summary, therapy notes, test results and reports, anesthesia records, history and physical, operative report, physician's progress notes, physician's certification and plan of care, physician orders, complete medical record. Sample additional documentation request or ADR. Recovery Audit Contractor. Region 3. Date, March 12, 2025. Provider name. Provider number, PTN. NPI. Address. Subject, additional documentation request, ADR. Claim number. Dates of service, January 8 to 10, 2025. Patient name, Jane Doe. HICN/MBI. MSDRG, 871, septicemia or severe sepsis without MV greater than 96 hours with MCC. Amount paid, $14,862. Reason for request. The Recovery Audit Contractor has selected the above claim for complex medical record review to determine whether the inpatient admission and associated services were reasonable, necessary, and appropriately coded according to Medicare coverage, coding, and billing guidelines. Specifically, the RAC will review 4. Medical necessity of the inpatient level of care. Clinical validation of the diagnosis of sepsis. Accuracy of MCC coding. Requested documentation, copies of the following. Complete medical record for the inpatient stay, including admission history and physical. Emergency department record. Progress notes and consultations. Physician orders and nursing notes. Diagnostic test results and lab reports. Discharge summary. Any related outpatient or prior admission records relevant to the episode of care. Supporting documents used for coding and billing, including coding summary sheets. Submission instructions. Due date. Please submit all requested documentation within 45 calendar days of the date of this letter. Submission methods. Electronic submission, preferred via the CMS Secure RAC portal. 1. Fax, 800. 2. Mail. Recovery Audit Contractor Region 3. Attention, Medical Records Department. 400 Compliance Avenue, Suite 300. Atlanta, Georgia 30339. Failure to respond. If the requested documentation is not received by the due date, the claim will be denied, and any overpayment will be recouped. Questions or assistance. If you have questions regarding this request, please contact RAC Customer Service. 1-877 RAC Help. 1-877-722-4357. Email, provider.support@racregion3.com. Sincerely. Recovery Audit Contractor, Region 3. Centers for Medicare and Medicaid Services, CMS. RAC vs. MAC vs. ZPIC/UPIC, Compliance Oversight Comparison. RAC, focus on recouping improper payments. MAC, handle claim processes. ZPIC/UPIC, investigate allegations of fraud. Compliance training tip, encourage documentation accuracy. High-risk target areas. Short inpatient stays. High focus on cases under 2 midnights. Many of these could be billed as outpatient or observation, so RAC challenge medical necessity. Medical necessity. Denials often occur when the documentation doesn't clearly explain why inpatient care was required. Example: chest pain patient admitted inpatient but quickly ruled out for MI, denial if documentation lacks risk justification. High-cost DRGs. Sepsis, pneumonia, respiratory failure, malnutrition, encephalopathy. These impact DRG assignment. Higher reimbursement possible creates more audit scrutiny. Procedures. Orthopedic, spinal fusions, joint replacements. Cardiac, stents, defibrillators. These are expensive procedures where documentation and coding must be precise. HACs and POA. RAC often review hospital-acquired conditions and present on admission indicators. If not documented clearly, the hospital may lose DRG weight or face payment reduction. Sample RAC denial letter. Recovery Audit Contractor Region 3. Date: May 10, 2025. Provider name. Provider number, PTN. NPI. Address. Patient name, Jane Doe. HICN/MBI. Claim number. Dates of service, January 8 to 10, 2025. MSDRG, 871, septicemia or severe sepsis without MV greater than 96 hours with MCC. Amount paid, $14,862. Subject, notification of overpayment, RAC complex review determination. Dear Provider, the Recovery Audit Contractor for Region 3 has completed a complex review of the above-referenced claim under the authority of the Centers for Medicare and Medicaid Services, CMS. After review of the submitted medical record, we have determined that the inpatient admission was not medically necessary based on the documentation provided. Basis for denial. Our clinical review found that the patient did not meet inpatient level of care criteria as defined by Medicare guidelines. Specifically, the documentation indicated admission for chest pain, however, serial troponins were negative, EKGs were non-ischemic, and symptoms resolved within hours. The provider's documentation did not clearly describe the severity of illness or intensity of services that required inpatient admission. Observation or outpatient management would have been appropriate for this presentation. Therefore, this claim has been denied as not reasonable and necessary for the inpatient level of care under Section 1862, A.1a, of the Social Security Act. Financial impact. The overpayment amount identified is $14,862. CMS will initiate recoupment of this amount unless you request redetermination within the specified timeframe. Appeal rights. You have the right to appeal this decision. To request a Level 1 redetermination, please submit your appeal to your Medicare Administrative Contractor within 120 days of the date of this letter. Your appeal should include a copy of this denial letter, a detailed statement of disagreement with supporting rationale, any additional clinical documentation supporting medical necessity. How to submit an appeal. Mail your request to Noridian Healthcare Solutions, MAC, Jurisdiction E. Redeterminations Department. P.O. Box 6742. Fargo, North Dakota 581086742. Fax, 800-555, Red 1. Email, redeterminations@noridianmedicare.com. Questions. For questions regarding this determination, contact the RAC provider support line at 1-877-RAC-HELP 1-877-722-4357. Sincerely. Recovery Audit Contractor, Region 3. Centers for Medicare and Medicaid Services, CMS. CDI and Coding Strategies for Denial Prevention. CDI Role. 1. Frontline defense against denials. 2. Clarify ambiguous, vague or incomplete documentation. 3. Ensure diagnoses like sepsis, malnutrition, respiratory failure meet clinical criteria. Coding role. 1. Accurately code based on provider documentation. 2. Confirm codes reflect the true severity of illness and medical necessity. Strategies. 1. Internal audits, pre-bill audits of high-risk cases. 2. Provider education, teach common pitfalls, example rule-out language. 3. Compliant queries, used to clarify documentation proactively. 4. POA accuracy. Ensure hospital-acquired conditions are documented correctly. 5. Teamwork, CDI plus coders plus providers reviewing denial trends together. Appeals process and financial impact. Understanding the cost, complexity, and strategy behind RAC appeals. Appeals process. Level 1, redetermination, handled by MAC. Level 2, reconsideration, by independent QIC. Level 3, administrative law judge, chance to present case to a judge. Level 4, Medicare Appeals Council, reviews ALJ decisions. Level 5, Federal District Court, final option, but costly and rare. Financial impact. RAC recoup billions annually for CMS. Even one denied case can cost thousands in lost revenue. Defending audits requires significant staff time, example are the AHIMA, ACDIS, legal and compliance. Hospitals must balance between appealing versus improving documentation upfront. Key points. Appeals can take years to resolve. Hospitals often see high success at the ALJ level, but the backlog is huge. Deciding whether to appeal depends on the cost, likelihood of success and resources. Teaching tips for CDI and compliance teams. 1. Think like an auditor. Train staff to review the record as a third-party reviewer, not as someone who cared for the patient. Ask, if I only had this chart, would inpatient care clearly make sense? Remind providers, intent is not defensible, documentation is. 2. Make medical necessity explicit. Encourage documentation of why inpatient care was required, not just what was done. Providers should clearly describe A. Severity of illness. B. Risk of adverse outcomes. C. Intensity of services. Especially critical for short stays and 2 midnight cases. 3. Strengthen high-risk diagnoses. Focus CDI reviews on RAC hotspots, examples are sepsis, respiratory failure, malnutrition, encephalopathy. Ensure diagnoses are supported by clinical indicators, treatment, and provider assessment. Avoid vague or copied forward language. 4. Present on admission and HAC is critical. Educate providers on the importance of present on admission documentation. Missing or incorrect POA indicators can A. Reduce DRG weight. B. Trigger RAC denials. C. Lead to payment penalties. CDI should query early when POA is unclear. 5. Use compliant queries strategically. Queries should clarify, not lead. Use open-ended, compliant language tied to clinical facts. Focus on A. Level of care justification. B. Clinical validation of diagnoses. C. Cause and effect relationships. 6. Track trends, not just denials. Monitor A. Common denial reasons. B. Frequently challenged DRGs. C. Providers or service lines with repeat issues. Use RAC data to drive targeted education, not blame. 7. Appeal strategically, not emotionally. Not every denial is worth appealing. Teach teams to evaluate A. Dollar amount. B. Strength of documentation. C. Likelihood of success. D. Staff resources required. Emphasize that prevention is cheaper than appeal. 8. Turn denials into education. Use de-identified RAC denials as A. Case studies. B. Provider education examples. C. CDI team training tools. Show before and after documentation examples to highlight improvement opportunities. 9. Encourage cross-department collaboration. RAC defense is not just CDI or coding, it's HIM. Case management. Compliance. Revenue cycle. Medical staff. Promote regular interdisciplinary RAC review meetings. Physician, hospitalist, education. Documentation that protects patient care and hospital revenue. Clinical decision-making. 1. Document the why, not just the what. Clearly explain why inpatient care was necessary, not just what was done. Helpful phrases include high risk for clinical deterioration due to requires inpatient monitoring because given comorbidities and abnormal findings, inpatient level of care is warranted. Auditors rely on your documentation to understand your clinical judgment. 2. Medical necessity. Include patient-specific risks, comorbidities, and monitoring needs that support inpatient admission. 3. Short stays matter. Short inpatient stays, 2 midnights, are closely reviewed. Your documentation should clearly justify the level of care chosen. Be sure to document A. Patient-specific risks. B. Abnormal findings. C. Monitoring or interventions that required inpatient care. Length of stay does not determine necessity, documentation does. High-risk documentation areas. 4. High-risk diagnoses. Conditions like sepsis, respiratory failure, malnutrition, and encephalopathy require clear clinical support. 5. POA and hospital-acquired conditions. Clearly indicate if a condition was present on admission. Missing POA documentation can reduce payment, trigger denials, and create compliance issues. Best practice takeaway. Strong documentation upfront. 1. Supports your clinical decisions. 2. Reduces unnecessary queries. 3. Minimizes audit burden. 4. Protects hospital reimbursement. Key message: your documentation tells the story of the patient's risk and your medical decision-making. In conclusion, this is the summary of key takeaways. 1. Documentation must stand on its own. Review charts as a third-party reviewer, not as the care team. Ask: does this record clearly justify inpatient care? Intent is not defensible, documentation is. 2. Make medical necessity explicit, especially critical for short stays. Clearly document why inpatient care was required, include severity of illness, risk of adverse outcomes, intensity of services, and avoid assuming the rationale is obvious. 3. Strengthen high-risk diagnoses. Common RAC targets are sepsis, respiratory failure, malnutrition, encephalopathy. Ensure diagnoses are supported by clinical indicators, treatment provided, provider assessment. 4. POA and HAC accuracy is critical. Errors equals payment risk. Missing or incorrect POA indicators can reduce DRG weight, trigger RAC denials, lead to payment penalties. CDI should query early when POA is unclear. 5. Clarify, don't lead. Use open-ended, compliant query language and focus on level of care justification, clinical validation, cause-and-effect relationships. 6. Use data to prevent repeats. Monitor common denial reasons, frequently challenged DRGs, repeat service lines or providers. Use RAC trends to guide targeted education. 7. Not every denial is worth appealing. Consider dollar amount, documentation strength, likelihood of success, staff resources required. Prevention costs less than appeal. 8. Best learning tool. Use identified RAC denials as case studies, provider education tools, CDI team training examples. Show before versus after documentation improvements. These are the references used for the presentation. Thank you for watching. Make sure to click subscribe, follow, and stay updated with our latest content. For just $25, you can access 1 hour of continuing education by clicking or copying the link below. To earn your certificate, simply complete the evaluation.